Hi, this is Elliot Fishman, and welcome to the January 2019 CT is Us quiz. The first quiz of what should be a wonderful 2019. I'm sure you hear the fireworks going off right behind me. We're recording this at midnight, December 31st. I don't know. Anyway, Happy New Year. And we have 10 terrific cases this month, so let's get started. In this case, patient has hepatitis C. What's the best diagnosis? When you look at the axial images alone, you see approximately a 2-centimeter hypervascular mass in the dome of the liver. When you look at the 3D cinematic rendering, you see the neovascularity feeding this mass. This is just a beautiful example of a malignancy. In a patient with hepatitis C, the likely diagnosis is, of course, a hepatoma. This is not the appearance of a hemangioma, which typically has puddling. This is not the appearance of focal nodular hyperplasia. And this could be metastatic renal cell carcinoma in theory, but usually with the Mets, you don't see the feeding vessels, you see multiple lesions, and I already told you it's hepatitis C, which was a great hint. So hepatoma is the correct answer. This patient had a widened mediastinum on chest x-ray, and so what's the best diagnosis? I'm showing you two different images, one from above and one straight on with cinematic rendering. And if you look at both sets of images, it's a very nice appearance. Notice on the view looking down, you see the vessel going from left to right, from the aorta, going behind the esophagus, coming to the right, and that's a classic description of an aberrant right subclavian artery. You can see the aberrant right subclavian artery on the coronal cinematic view as well. This is not a true aortic ring, of course, which means the trachea and or esophagus is surrounded and there's narrowing. It's not an aberrant left subclavian, it's an aberrant right subclavian. Just a very nice example, and I thought you'd like the cinematic rendering. This patient has flank pain. What's the best diagnosis? Well, again, I've given you a cinematic rendering, which is I'm trying to show you how well it works in select cases. There's a large infiltrating tumor in the liver with extensive neovascularity. That's not the appearance of an abscess, and the neovascularity is not the appearance of hepatic adenoma in most cases, and it's not a giant cavernous hemangioma. Giant cavernous hemangioma have puddling. This is neovascularity. Yes, I could argue it could be hepatic adenoma, but this was a hepatoma. Just a beautiful example. If it was a hepatic adenoma, it would be a malignant degeneration of hepatic adenoma into hepatoma. So hepatoma is the correct answer. The least likely diagnosis in this case is, I'm showing you what is patchy areas of wedge-shaped decreased attenuation in both kidneys, worse in the left kidney than in the right. It could be renal infarction. In fact, in this case it was, and it could be acute or chronic pyelo. Sometimes I think it's hard to distinguish acute pyelo from renal infarction. Sometimes with pyelo, it involves the entire kidney, though renal infarcts can as well. Sometimes when it's just wedge-shaped, it can be difficult. The one thing this is not is lymphoma. Lymphoma is typically more mass-like. You don't see wedge-shaped defects. It's infiltrative, and most typically the kidney is going to be enlarged. This patient has HIV and has rectal pain. What's the best diagnosis? On scans to the upper abdomen, you see a lot of nodes in the paraortic region, the perirenal region, and in the mesentery. So you might even think about lymphoma. You think of MAI. When you get to the pelvis, there are large nodes in the pelvic sidewall, inguinal nodes, and I don't show it to you very well, but the inguinal nodes are enhancing, and then there's a mass in the rectum, an infiltrating process in the rectum that's enhancing. If you said adenocarcinoma, I'd have a hard time saying you were wrong. If you said lymphoma, I guess lymphoma in the colon is uncommon, but you could be right. But I was pushing the HIV, and this indeed was Kaposi sarcoma. We did read it correctly. We suggested Kaposi's, but the images I had more nodes, particularly vascular nodes. And when I start seeing an enhancing rectal lesion and vascular nodes, and it's an HIV patient, I'm thinking Kaposi sarcoma. Fortunately, we don't see these cases very commonly anymore. During the AIDS epidemic, they were indeed very, very common. The most likely clinical finding in this patient is And the findings of note are very, very bright adrenal glands. And we lecture about that in the adrenal talk. When you see very bright adrenal glands, you better worry the patient is hypotensive. It's not hypertension. It's not an Addisonian crisis. It's not chest pain. The patient's hypotensive. Sometimes the clinicians know it's an ICU patient, it's a post-trauma patient, but in other cases they do not know, and that information is very, very important, obviously. The best diagnosis in this patient, wonderful example, large spleen with infiltrating process seen on arterial and venous phase imaging. Mononucleosis can give you a big spleen, but not infiltrating like this. Thalassemia can give you a big spleen, and it can have a funny appearance with sequestration. Kaposi is uncommon in the spleen, usually funny enhancement, not this infiltration. An infiltration like this, big spleen, I'm thinking lymphoma. And this was a B-cell lymphoma. Just a beautiful example of infiltration. You notice that the venous phase is better at showing the infiltration than the arterial phase, but you can see them well in both phases. The most likely diagnosis in this 50-ish-year-old female is there's a vascular lesion, tail of pancreas, which is shown on the MIP imaging as well as on the cinematic imaging. You could consider, based on location, an accessory spleen, but it is brighter than the spleen. It's not an adenocarcinoma, and the kidneys are present, so it's unlikely to be renal cell metastatic. This is a classic example of a pancreatic neuroendocrine tumor. Just a very, very nice example. In this middle-aged female, the best diagnosis is, forget the possibilities. Look at this mass coming off the pancreas, septations, calcifications, multiple variable cysts, classic for serous adenoma. Spen tumors, not middle-aged females, young females, not so many septations typically. This is not an IPMN, and MCNs don't have so much septations. MCNs can have calcifications, but it's typically peripheral. So that's not going to be the case here. In this patient with back pain, the least likely diagnosis, what's least likely? When you look, there's a mass which appears to involve or arise from the left psoas muscle and track straight down along the course of the iliopsoas. There's mass effect on the aorta and iliac artery. It doesn't really look like lymphoma, though you could consider lymphoma, just anything with big retroperitoneal masses. Liposarcoma is a good choice. You say it's not fatty, but a lot of the retroperitoneal liposarcomas, and this in fact was a retroperitoneal liposarcoma, really don't show much, if any, fat. A psoas bleed, the psoas looks enlarged, it tracks the length of the psoas. I guess it's a possibility. What this isn't is a neurofibroma. Neurofibroma arise from the canal. They can cause bony erosion. They can be large, and they're typically low density. They don't track along the muscle as this one does. So neurofibroma is the least likely diagnosis. The other ones are all possibilities, and liposarcoma was indeed the answer. So that's 10 terrific cases. I hope you enjoyed them. And with that, hope you have a great month. Ciao, ciao, ciao. Bye. Hi, this is Elliot Fishman, and welcome to the February 2019 CTSS quiz. I hope your winter is going well. We haven't had snow really yet. I think we had a little bit. So hopefully February will not be a bad month, and hopefully the groundhog will be happy. Anyway, we have 10 terrific cases for you, and without further ado, let's get started. The most likely diagnosis in this patient is, gave you two great images, one axial CT mid-abdomen and one cinematic rendering. What you can see on the axial imaging are multiple soft tissues off the skin. They're low density, homogeneous, they're not really enhancing. And then if you look at the patient's entire chest and abdomen, you see there are too numerous to count lesions in the chest wall, abdominal wall, pelvis. Lymphoma can give you subcutaneous nodules, but there's usually more skin thickening, irregularity, and enhancement. Think about mycosis fungoides. Melanoma, solid masses, enhancing, and not that many probably. Lipomatosis, this doesn't look like fat. With lipomatosis, you don't get that many lesions or that large. This is a classic example of neurofibromatosis. These are all multiple cutaneous neurofibromas. Just a beautiful example. The most likely diagnosis in this 30-year-old with left lower quadrant pain. When you look at the images, coronal and a MIP imaging, you see a thickened loop of small bowel to the left of midline. When you look at the MIP, you see the most beautiful comb sign. The comb sign was almost classic, though not perfect, for Crohn's disease. Also, you see a lot of fat around the bowel, fibrofatty proliferation. This is not the appearance of ischemic colitis. It's not the appearance of infectious colitis. There's no mass effect or infiltration. This is not lymphoma. The fatty infiltration, the comb sign, classic example of Crohn's disease. Just a beautiful case. This patient has a mass in the neck. What is it? Again, axial imaging and then a cinematic look up from below. Beautiful hypervascular mass surrounding the patient's left carotid body tumor. This is a paraganglioma. No, it's not lymphoma. Lymphoma does enhance as much, and you would see more nodes if there was lymphoma. It's not in the thyroid. It's not a neurofibroma, which are typically low attenuation. Classic paraganglioma. Just a beautiful, beautiful classic case. This patient has small bowel obstruction. What's the cause? Well, you look at axial and then volume rendering. You see multiple dilated bowel loops. And if you look at the volume rendering, which gives you the full abdomen, you can see the transitions right up a quadrant. You look back at the axials as well as on the volume rendering, you see a solid mass. That's in the region of the hepatic flexure. Unfortunately for this patient, it's not a case of adhesions and it's not intussusception. It could be lymphoma. I guess that's a possibility. Lymphoma, I have seen infiltration of the large bowel. I have seen terminal ileum lymphoma with intussusception into the large bowel. But this is not an intussusception. This is solid mass. And most likely, and this was in fact an adenocarcinoma of the patient's hepatic flexure. Just a beautiful example. Now in this case, I asked for the most likely diagnosis. Well, the first thing you notice is the left kidney is missing and there's a clip. So the patient, I guess you could have had trauma or infection, but when you look at the right kidney, you see multiple filling defects in the renal pelvis. And when you look at the bladder carefully on the axial imaging at about the level of the right UV junction at about 7 o'clock, you see an enhancing mass in the bladder. So now I'm saying left nephrectomy, tumor in the renal pelvis on the right, and bladder mass. This is multifocal transitional cell carcinoma. It's not going to be a renal cell or clear cell, and it's not the appearance of TB. I guess only looking at a missing kidney, you could say maybe the patient had renal cell, but the appearance of everything we see here, beautiful example of multifocal transitional cell carcinoma. This patient has abdominal pain, acute abdomen. What's going on? You look at the axial imaging, it's the classic mass effect appearance of an intussusception. And you can see it very nicely on the volume rendered views as well. You can see the stretching of branches off the SMA, that telescoping of the intussusception. Now, intussusceptions can be due to malignant tumors or benign tumors. You can see them without tumors like in sprue or Crohn's disease. But in this case, you can see there's a mass within the intussuscepted portion. This patient also has an additional masses in the small bowel. Look at the left lower quadrant. There's a mass in the patient's bowel as well. And this patient, in fact, had multiple masses. And this was, in fact, a patient with Peutz-Jeghers syndrome. But the cause for the pain is intussusception. Just a beautiful, beautiful example. Now, in this case, I ask you what's the best diagnosis for this patient with chest pain. Axial imaging, faint calcifications, which correspond to a dilated left ventricle, which is dilated and irregular. And if I showed you the 4D, there was thinning of the myocardium. The ventricle was enlarged, a classic appearance for left ventricular aneurysm. It's not endocarditis, it's not myocarditis, and this has nothing to do with Marfan's disease. What about this case? Well, this is kind of interesting. Patient's post-ileostomy was now having pain. What's going on? What you see on the coronal view, volume rendering, as well as on the cinematic rendering, is dilated loops of bowel, so you're thinking obstruction. Now, maybe it's simply adhesions. That's unlikely. Maybe it's post-op change, ileus related to the recent surgery. But when you look at the lumen, there's high-density material. That is blood. There's a question of a little dot on one of the small bowel loops, a bit lower, and perhaps this is the site of bleeding, but whether you're looking at the volume rendering or the cinematic, this is a patient with bleeding into the small bowel, beautifully shown based on its high density, and this was due to a small bleed in this patient who was post-op. Patient with weight loss, what's the best diagnosis? You see a large mass involving the lower esophagus and GE junction and gastric fundus. If I only showed you the image on the right, you would say gastric cancer, maybe lymphoma, perhaps a GIST tumor. Image on the left, esophageal cancer, very bulky, maybe lymphoma, something growing up from below or coming up down. So lymphoma is indifferential. Adenocarcinoma GE junction alone is kind of bulky for that, but I guess I couldn't say no. It's not extramedullary hematopoiesis that would show enhancement, and surely doesn't have the appearance. This was an unusual case. This was a gastrointestinal stromal or GIST tumor of the GE junction, and was read as a GIST tumor of the stomach growing upward. GIST tumors can occur anywhere: small bowel, large bowel, colon, esophagus, stomach. 70% are in the stomach. This is very unusual. I hardly ever see a case that kind of crosses esophagus and stomach junction. Just a beautiful example. The patient had GI bleed. What's the cause? When you look on the axial images, you see in the bowel loop just to the left of midline a high density zone and a low density zone. And when you look at it on the coronal view, you can see it's in the proximal jejunum and it's smooth with calcifications. What is it? Well, it's not the appearance of varices. It's not the appearance of angiodysplasia, which show multiple branch vessels that are dilated. It's not the appearance of a carcinoid tumor, which is typically vascular, but I guess it's not always going to be vascular. GIST tumors can be vascular as well, but not always, and it's more likely for GIST to calcify or a carcinoid. Well, they both can calcify, but it's unusual to find a carcinoid that has basically no vascularity, so I would have to go with a small bowel tumor. I probably would have picked something like an adenocarcinoma or metastasis, but this was, and since it's your only choice, a GIST tumor with dystrophic calcification, and you can see the mass effect. So, my friends, those are 10 incredible cases. I got them all right. I guess I knew the answer and I chose the cases, but that's just not the point. Hopefully you got them all right, but even if you got none of them right, hopefully you learned something, and hopefully when you see these findings again, you'll be right on the money. And with that, have a great day and see you later. Hi, this is Ellie Fishman, and welcome to the March 2019 quiz. Hopefully we're reaching spring, so let's spring forward with 10 terrific cases. On this case, I asked you what's the most likely diagnosis for what appears to be a 7-centimeter adrenal mass. When you look at it in the axial view and the coronal view, you see areas of calcification and fat within the lesion, perhaps a little bit of enhancement. The fat is a home run diagnosis. This is classic for myelolipoma. Although we know adrenal carcinomas can sometimes have fat, it usually is when they're very aggressive tumors invading the periadrenal fat. This is classic myelolipoma. It's basically a leave-alone lesion. It's not metastatic. It's not a primary tumor. Nothing to worry about. Obviously, some myelolipomas can bleed, and sometimes they cause symptoms, and patients will have them resected. But when it has a lot of soft tissue like this, typically it's not going to be problematic. In this case, what's the gastric mass? Well, when you look at the axial views, you see a 2-centimeter lesion that appears to be slightly enhancing to the left of midline. When you look at the coronal view, you recognize it's coming off the inferior aspect of the greater curvature of the stomach. It's slightly enhancing, it's smooth as water density. That's not the appearance of an adenocarcinoma, that's not a lymphoma, and it's not an implant. This is a GIST tumor. Now remember, we think about GIST tumors being larger, but they can be small. I think a lot of people will have these simply followed. when they're this size. Just a very nice example. This 30-ish-year female had abdominal pain. What's the best diagnosis? Now, if you just look at the lesion, it's a complex cystic lesion with stranding. Now, if you said PID, I guess I could not argue with you. This could be PID, multiple septated, involving the region of the left ovary. That's a possibility. If you said ovarian cancer, I guess you could think about an ovarian mass. If you thought about complex ovarian cysts, I could say that as well. But in this patient with chronic abdominal pain, what I wanted you to think about was endometriosis. Endometriosis is a tough diagnosis because it can look like other things. And in this case, a tubal ovarian abscess would not have been a bad thought, but this was endometriosis. Sometimes MRI can be helpful in that regard as well, but a good example of endometriosis. What's the most likely pancreatic diagnosis in this case? You see a cystic lesion in the pancreatic head, basically into the uncinate process. It's cystic, but you see what appears to be a solid component. There's a thickened septation and a solid component. This is not a simple IPMN. Could this be a mucinous cystic neoplasm? I guess so. It's not a serous cystic adenoma either. What you have to think about when you see a cystic lesion with thickened septation and a mural nodule is an IPMN with high-grade dysplasia. These are the typical precancerous lesions, or these are the ones that will be resected. Just a very nice example of that lesion. What's the best diagnosis in this case? I'm showing you two images with cinematic rendering, multiple lesions on the patient's skin. You can get skin involvement with lymphoma, mycosis fungoides, but not this extensive. Melanoma can give you skin lesions, but not this extensive. Allergic reaction to contrast can give you cystic lesions, but again, not this extensive. This is a classic example of neurofibromatosis. Just a very impressive example. It's interesting how the neurofibromas get compressed around the patient's waistline. Kind of interesting. This patient had a partial right nephrectomy and now has hematuria. What's going on? When you look at the arterial phase imaging on the axial and the 3D, you see what appears to be a very bright vascular structure in the kidney around the cystic zone where the patient had their partial nephrectomy. You see it on the coronal view. You see it connecting the renal vein and renal artery. This is a pseudoaneurysm of the renal artery with early venous opacification. It's not just an active bleed. It's too well defined. It's not an infarct, and it's not renal artery occlusion. Pseudoaneurysms can occur with partial nephrectomies. They can occur with ablation. It's kind of rare, but this is a really nice CT example. In this patient with abdominal pain, the least likely diagnosis is, well, let's look at the images. The axial, you see a model density in the region of the antrum of the stomach, anterior to pancreas. And when you look at the coronal view, there's a perforation along the antral region on the lesser curvature. Now this, I guess, could this be a gastric diverticulum? I don't know. You could have outpouchings, but there's a break in the wall, and this is really extraluminal air and extraluminal fluid. This is a perforated ulcer. Now, could it be a perforated ulcerating gastric cancer? The answer is yes. Could it be a foreign body perforation? I guess I could think about that, but I don't see a foreign body. Now, B and C are both sort of possible answers. This, in fact, was a perforated gastric ulcer in a patient who had inflammatory disease. Hard to say there wasn't a cancer here, but I think the least likely diagnosis is a gastric diverticulum. When you have gastric diverticulum, they can contain food matter, but you see the outer borders and enhancement of the gastric wall. Here you do not see that. Just a really nice example. This patient has abdominal pain, and I'm showing you an axial image which shows marked small bowel thickening, and you see that particularly impressively on the 3D MIP. Look at that long segment of ileum that's involved. There's areas of dilatation, and you can see the large bowel is not involved. Now, this could be infectious enteritis. In fact, it was. You could think about a drug-related enteritis. It may be a bit extensive for someone like with ACE inhibitors. Graft versus host disease would be a possibility. The one thing this is not is peristalsis. Occasionally you can see focal dilatation of bowel and sort of changes in the caliber. but you don't see the irregularity in the picket fencing. This is surely some severe enteritis, which was infectious. D is the answer because that's surely the least likely diagnosis. This patient presented to pancreatic conference with suspected pancreatic cancer. I'm asking you what's the best diagnosis. When you look, in fact, the pancreas is displaced, and what you really see are nodes in the otocaval space in the peripancreatic region. And look at the mass effect when you look at the coronal view. That really gives you a feel of how extensive the process is. So this is not pancreatic adenocarcinoma. And there's no enhancement, so this is not a neuroendocrine tumor. I guess you can think of melanoma. I've shown you a few examples of melanoma metastatic to duodenum, and it can be nodes in the peripancreatic region. But when you see the nodes in the peripancreatic region, and really the epicenter in the mesentery and this kind of sheet of nodal mass, that's going to be lymphoma. And most classically, as in this case, it was a B-cell lymphoma. This patient presented with left upper quadrant pain, and I asked what the least likely diagnosis is. You see ascites in the abdomen or blood. You see a large spleen that's mottled in enhancement, and you see active bleed. The fact is, this was a patient with CLL, with spontaneous bleed, so that's the answer. But I've seen mononucleosis, big spleen, and spontaneous bleed, and the spleen is often irregular in contour. That's a possibility. Sarcoid involves the spleen. I haven't really seen a case of sarcoid with spontaneous splenic or hepatic rupture, but I guess it could happen, or spontaneous bleed, it could happen. This is not a normal spleen with spontaneous bleed due to mild trauma. The spleen is enlarged, it's infiltration. We know patients who have pseudocysts in the spleen, like alcoholics, can have splenic rupture with even very mild trauma. You can have stab wounds that can give you bleeding, I guess, but here, the mottled enhancement of the spleen, the lack of the moire pattern, the active bleed, the fluid in the subcapsular space, the least likely diagnosis is a normal spleen with mild trauma. Anyway, those were 10 terrific cases. I gave you a lot of least likelies because I wanted to mix things up. Hopefully I showed you a few cases you haven't thought about, and hopefully you got them all right, but more importantly, hopefully you learned something. And we'll see you back in April. Catch you later. Bye. Hi, this is Elliot Fishman, and welcome to the April 2019 CTisus quiz. There are going to be no April Fool jokes, but we're just going to have simply 10 terrific cases for you. So without further ado, let's get started. In this first case, I asked you what's the least likely diagnosis in this patient with left upper quadrant pain. If you look at the images, what's most impressive to me on the axials and then well shown on the coronals is the markedly thickened gastric folds. In fact, when you have gastric folds that are only in the fundus or mainly in the fundus, you can even think of Menetrier's disease, which is kind of rare. You could think of lymphoma infiltration. That's definitely a possibility. Adenocarcinoma, it could be, but I would have picked lymphoma first. In fact, this was a case of chemical gastritis. I thought it was malignancy. This patient was scoped, and it came back chemical gastritis on biopsy from NSAIDs. We do talk about how the fact that you can be fooled at times, that sometimes inflammatory disease, particularly gastritis due to drugs, can simulate malignancy, particularly early malignancy. The one thing this is not is a normal stomach that's not distended. We do make the point that when the stomach is not distended, you can be fooled. But here, the stomach is well distended, and those folds are markedly thickened, and you can see the abnormal enhancement. So the least likely is number D. This is a great case, and the challenge is to only show you 2 images. And what's the most likely diagnosis? Well, what you see is a cystic mass in the head of the pancreas. It looks like there's some vascularity along the rim of the lesion as well as within the lesion proper when you compare arterial and venous phase imaging. Now, I guess if this patient was 18 years old and female, this could be a SPEN tumor. We've seen SPEN tumors that are cystic. That'd be a good possibility. Neuroendocrine tumor, usually they're more vascular. IPMNs, if this was an IPMN, it would be an aggressive malignancy in an IPMN. The most likely diagnosis, you can see the septations. Though the enhancement's a little bit strange, I'm still going to go with a serous cystadenoma. I surely could not exclude a neuroendocrine tumor, but it would be atypical, but this was a serous cystadenoma. In this case, I asked for the most likely diagnosis. Forget the answers I listed. Look at the liver. The liver on the axials and the volume rendering is markedly cirrhotic. And then you see evidence, best shown on the 3D, of a 2.5 centimeter hypervascular lesion. And if you look back toward the venous, you can see the lesion is there, or rather to the axial. The lesion is there, and there's some neovascularity. You have a cirrhotic liver. Remember, we never call hemangiomas in cirrhotic livers. Plus, this doesn't look like a hemangioma. There's no peripheral puddling. FNH, the neovascularity to the lesion is not FNH. And the hepatic adenoma, if this was a hepatic adenoma, it would have been a hepatic adenoma that became a hepatoma. Cirrhotic liver, you're always thinking about hepatoma. And in fact, this was a small hepatoma with vascular invasion. The most likely diagnosis in this 30-ish-year-old is, it's a beautiful example using two different types of cinematic rendering. Look at the patient's dilated left subclavian artery. To me, when I see that and then, aha, there's narrowing just beyond it, that's classic coarctation. We wrote that in the article we published a couple of years ago about coarcs, talking about the large left subclavian, and this is just a beautiful example. Again, the sagittal view of the sagittal 3D in this case is optimal for looking at the aorta. Some people call it a candy cane or whatever else you want to call it type presentation, but just a very nice example. In this case, I'm asking you for the least likely diagnosis. Well, what are you seeing here? On both the MIP imaging and the cinematic, you see a very, very large spleen with multiple low-density lesions. If I had to pick the answer here, I would have said CLL. CLL typically gives you the largest spleen. The other thing, mononucleosis in a young patient, you could have huge spleens of mononucleosis, but this is even there almost too large. In fact, this was a case of polycythemia vera with myelofibrosis. Just a very, very impressive example. Again, I would have favored leukemia. In fact, this patient has had bone marrows many times because with polycythemia vera, you worry about malignant transformation, but this has not happened. This is not sickle cell disease. Remember, classically, sickle cell is a small autoinfarcted spleen. Sometimes with sickle thalassemia, you can see a larger spleen with some calcification, with areas of infarction, but nothing of this size range. So that's the least likely diagnosis. What's the most likely diagnosis for this mass in the left lower quadrant? When you look at it, it's round, it's enhancing, and I know it would be easier if you had the whole data set, but in case you didn't notice, there's no spleen. I've shown you MIP images and volume rendering, and you would see a spleen if there was one. There isn't a spleen present. Yes, you can think about a carcinoid, but that gives you a desmoplastic reaction. It's not so smooth. In a large node, that's a really strange location, and the node would have to be enhancing, and I see no other nodes. A mental implant, I guess you can consider that. It's a little bit to the left, but you can consider implants, but again, typically so round, so homogeneous. And once you realize that this patient does not have a spleen, you know you're dealing with an accessory splenule. And remember, these accessory spleens can simulate nodes or masses on the omentum or mesentery. They can simulate pelvic masses, all sorts of problems. So it's something very important to consider when you're reading scans and you notice the spleen is missing. This pregnant patient had an acute abdomen. What's the best diagnosis? Again, we don't want to do CT in pregnant patients unless there's clinical dilemma. Here, there was concern about an incarcerated bowel. They had no idea the patient had this bleed. Beautiful example of a rectus sheath hematoma. There was no incarcerated hernia, there was no SBO, and there was no appendicitis. Just a beautiful case. And you can see I could not find active bleeding, but the bleed is recent with the blood fluid levels so nicely defined. The most likely diagnosis in this case, this is a wonderful study. If you look at the coronal views, you can see that there's soft tissue surrounding the aorta from the diaphragm down, encasing the renal arteries involving the SMA and celiac. You also can see it extend straight down along the aorta, along the course of the common iliac arteries. And you can see it also appears to involve the renal arteries. When you look at the excretory phase, you see the duplicated system on the right, but what you're really seeing is the fact the ureters are being medially displaced. They're kind of tied in. You can see how they come really close to the vascular calcifications in the aorta. So what gives you soft tissue infiltration around the aorta, medial deviation of the ureters? That's going to be retroperitoneal fibrosis. Lymphoma, more likely than not, would have displaced the vessels laterally. A leaky aortic aneurysm with perianeurysmal fibrosis. I guess that's one of the causes of retroperitoneal fibrosis. TB, you can get scarring, but not the symmetry. And with TB, you would have extensive calcification. So that's not the case. This patient had weight loss and fever. What's the most likely diagnosis? Obviously, when you look at the list, pancreatic cancer, lymphoma, metastasis, I'm thinking 3 malignancies, and then I put down autoimmune pancreatitis. If you look at the case, the head of the pancreas looks okay, but the body is edematous. And whether it's on the axial cinematic or on the coronal, you see the patchy enhancement, and particularly on the axial display, you see the low density around the pancreas. That's consistent with the classic cigar appearance of autoimmune pancreatitis. This was a wonderful example of autoimmune pancreatitis. Indeed, very, very classic. This patient had back pain. When you look at the lesion on the soft tissue images, there's a large presacral mass which really extends posteriorly into S1. It's infiltrating. You can see on the bone windows the bony infiltration, the soft tissue mass. Could this be a plasmacytoma? I would consider it, but then the bone would be more expanded. Could it be metastasis? I also would expect more bony destruction. Could this be a soft tissue sarcoma in front of the spine pushing in? Theoretically, yes, but unlikely. Sometimes you see rectal cancer growing upward, but that's markedly irregular. And this is very smooth. And this is a classic example of a chordoma. We don't see chordomas that frequently. Remember, this area, lumbar spine sacrum, as well as base of the skull, are the most common areas. So with that, 10 terrific cases, 10 terrific answers to 10 terrific questions. Have a terrific day. Bye-bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the May 2019 CTSS quiz. May means it's going to get warm out. May means the Masters is over and Tiger Woods won, and now comes the Kentucky Derby. But more importantly, here comes 10 incredible cases. So with that, let's get started. In this first case, this was a patient with abdominal pain, and I asked you what is the best diagnosis. It's kind of funny, when you look at the coronal view, you see what looks like some metallic artifact in the bowel. And when you look at the MIP imaging, you see a number of different metallic densities. If you stare at them quickly, you maybe say, well, it could be surgical clips or some other funny things. But the more you look at it, you realize these are safety pins. And this patient swallowed a number of safety pins and opened the safety pins before they swallow them. And all of us do see occasional cases of patients who swallow things, and this is one of the more dramatic ones. And obviously, this are not going to pass. The question is, what do you do? Do you go in and operate? What do you do? Can you make more problems than you solve? But of course, open safety pins can easily perforate. So it really is a challenge managing these patients. So again, foreign matter, we talk about retained sponges. This is a case, unfortunately, of a patient with psychiatric issues who swallowed a number of safety pins. In this 50-ish-year-old male with FUO, what's the best diagnosis? Well, when you look at the spleen, several things. It's enlarged, and there are multiple low-density lesions. Okay, this is not normal splenic enhancement. Remember, we get a moire pattern, but that's an arterial phase. This is more toward venous phase. I guess it could be sarcoidosis. Multiple low-density lesions are indeed possible. It could be lymphoma, and in fact this is lymphoma, primary splenic lymphoma. You do see in this case the patient does have nodes in the portal caval space, and you can see nodes with sarcoidosis as well. Both sarcoid and lymphoma can give you involvement of both liver and spleen. And of course splenic abscess is a possibility, right? Usually the more discrete, if you immunosuppress, multiple lesions can be splenic abscesses, and I would say splenic abscesses is pretty unlikely. But the least likely answer, of course, is normal splenic enhancement. This is definitely abnormal, and this indeed was Hodgkin's disease. This patient had pancreatic surgery, routine follow-up, and someone looked at this and said, aha, this is tumor recurrence. When you look at it, you say, well, it could be, I guess, in theory, there's all this haziness in the mesenteric fat, on the omental fat. What's going on? But I think we've learned that it's very common to get omental infarction, particularly with laparoscopic surgery. It looks like mass effect can be more solid. Usually it's this fatty appearance, has this haziness, has mass effect, but is stable and typically does not change. And this is a very nice example of omental infarct. In this case, I asked for the best diagnosis. Well, let's look carefully. The first thing you see on the CTA is really impressive narrowing of the aorta near and just beneath the renal artery. Then you also see marked dilatation of the IMA, and if you look carefully, there's narrowing at the takeoff of the IMA. There's also narrowing at the takeoff, particularly of the left renal artery. Now, aneurysms is good for Ehlers-Danlos, but not the stricture, and mid-aortic syndrome is something to consider, but would not explain the IMA and renal artery findings. And Williams syndrome is not going to be, that's usually supravalvular aortic stenosis. You can get narrowing of the aorta, but the findings, the key diagnosis in this case is neurofibromatosis. It's just a wonderful example of neurofibromatosis. Neurofibromatosis can present with hypertension because of renal artery stenosis. This patient has it. Can also cause narrowing of the aorta. This patient has it. Can also cause narrowing of other vessels, of the IMA in this case, and the patient has it. Just a really beautiful example. This patient has chest pain, and the question is, what's the best diagnosis? When you look at the axials, the patient has a type A dissection right by the patient's right renal artery. Indeed, very impressive. When you look at the coronal view, you wonder, could this simply be a large ulcer? But it's more than just an ulcer. It's really a dissection. Type A. Patient was lucky. The patient was managed. The patient had surgery. You could see how it's coming to the right renal artery. You could imagine right renal artery involvement or even tracking toward left renal artery. You can get infarction. So this is a beautiful example of a type A dissection. In this case, I asked you what's the least likely diagnosis in this patient with an FUO. What do we see? We see a cystic lesion with septations, dome of liver. We also see perfusion changes. Could this be necrotic tumor like a neuroendocrine tumor or colon cancer? Absolutely. Can this be an infarct? Usually they're more wedge-shaped, but I guess it could be. More likely, a cystic lesion with irregular margins without a history of malignancy is going to be a liver abscess, and indeed this was an E. coli abscess. This is not a liver cyst. Simple liver cysts can have septations, that's true, but they're not irregular. They don't cause perfusion changes unless they're very large, and this case has septations and slight nodularity and perfusion changes, and this was the least likely diagnosis would surely be a simple liver cyst. Great case. In this case, what's the best diagnosis? And remember, we've spoken about this before. If you look at it near the left UV junction, you see a less than 1 centimeter enhancing nodule, which shows well in the excretory phase as well. It's not a granuloma, it's not an AV malformation, and the high density, it's not a blood clot. This is classic bladder cancer. Remember, we've said anything enhancing in the bladder should be assumed it's cancer, period. And this was a cancer. This was not a study done for hematuria. It was a study done for aortic aneurysm, but the bladder gets distended because of water as an oral agent. And you could pick up incidental bladder cancers, so we always look carefully at the bladder. This patient had chest pain. What's going on? When you look at the axials, this left ventricle looks really weird. It looks saccular. And then if you look at the sagittal, you realize you're looking at a giant outpouching off the left ventricle. It's not a dissection, and it's not a simple diverticulum, and it's not an ulcer. This is a pseudoaneurysm. We've seen pseudoaneurysms due to trauma like stab wounds. We've seen pseudoaneurysms from large infarcts. Pseudoaneurysms are very problematic because they easily can rupture. And this is one of the largest pseudoaneurysms I've seen. And it's just a very, very nice example. This patient was sent in for a hepatoma. But when you look at the lesion, this is the importance of looking at phases. Even from the arterial phase, image on your left, you see peripheral puddling, central scarring. There's no cirrhosis. To me, this is a hemangioma. Stop the engines, get off. It's it. When you go a little bit later, you see the peripheral puddling and the filling in. The two images together, 100% classic cavernous hemangioma. This is over 5 cm, so it's a giant cavernous hemangioma. Hepatomas can have vascular changes around the periphery, but they're irregular. Things don't fill in a peripheral to central pattern. Hepatic adenomas and FNHs. FNH is typically hypervascular, matches the IVC, but is not peripheral to central. The same thing about hepatic adenomas. This is classic hemangioma. The best diagnosis in this case, I thought I'd show you a really nice brain perfusion. This was a stroke protocol. You look at the axial image, you see decreased enhancement and mass effect on the right side of the brain, in the middle cerebral artery distribution, and you can see when you do the stroke mapping and the perfusion mapping, this is a large ischemic infarct. Okay, just a beautiful exam. People now are considering whether MR is better than CT in the acute setting. CT is available. It's as good as MR, and it's what's done. Obviously, if you say, what else could this be? Lymphoma, possibly, though you would see more ventricular compression. Acute bleed, this is not a bleed. Infiltrating tumor, this is too homogeneous for being a glioblastoma, multiform, GBM. This is an infarct. So with that, I've shown you 10 terrific cases, not 9, not 8, not 7, to quote the count, 10 cases. So I hope you got them all right, and if you didn't get them right, I hope you learned something. And with that, happy to see you next month. Take care. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the June CTisus quiz. I hope your weather, we complained for a long time it was too cold. Now you're probably complaining it's too hot. But nevertheless, let's look at 10 terrific cases and see how well you do, and let's see if we all can learn something. In this first case of a middle-aged female, I asked what the best diagnosis is. When you look at the images, there's a coronal view and a cinematic. There's a complex cystic lesion in the body of the pancreas. Maybe there's slight prominence of the pancreatic duct, but that's the only finding. I like cinematic now to look at some of the texture of the lesions, and I think hopefully it's something we can learn from. Could this be an IPMN? It's kind of big. Theoretically, yes. MCN is very good in this location. Pseudocyst, patient no history of pancreatitis. But this lesion with the septations was a serous cystadenoma. I think sometimes you can have a problem with MCNs, but usually they're cystic, no septations, and you can see the septations better seen on the images with cinematic rendering. And so the best diagnosis in this patient is a serous cystadenoma. We know serous cystadenomas can grow. Usually if they're over 5 centimeters, they will be resected, but there is some variability in that. The question in this case is, what's the best diagnosis? I like this case because it's cinematic rendering, and it's one of our new views where we're looking in the lumen. You can see the patient has a type A dissection coming near the patient's right coronary artery, and you could see the flap really nicely with the endoluminal view. I think endoluminal views with cinematic rendering are going to be very helpful. We have submitted an article on that. We could do endovascular views previously with volume rendering, but I think this gives you a little better shadowing and a little better detail. You can see the left coronary artery. You also can see the patient's ventricular wall. So it's a very nice rendering, but the answer is A, type A dissection. This patient had nausea and vomiting, and what's the best diagnosis? If you look at the images I gave you in 3D, there's a markedly distended duodenum, and then as you track it to the past the ligament of Treitz, you see a mass present. And I guess this could be a lymphoma. Infiltration like this is not going to be a GIST tumor. They're typically exophytic. Crohn's, you have a long segment, some abnormal enhancement, but not this mass effect. If this was Crohn's, it would be a cancer on top of Crohn's. So what could this be? Well, it's proximal bowel. It's more likely adenocarcinoma. The obstruction is more common in adenocarcinoma than lymphoma, and this was adenocarcinoma of the proximal jejunum, causing the patient's obstruction and clinical symptoms. The best diagnosis in this case, we're dealing with a cystic lesion tail of pancreas with multiple cystic components. Now, IPMNs can have a cluster, but when I start thinking about a cluster, I'm thinking about a serous cystadenoma. Metastatic renal cell is typically hypervascular. MCN is typically body of pancreas. Again, maybe a thin septation, maybe not. But when I see a cluster, I'm thinking about serous cystadenoma, which was the correct answer in this patient. In this case, I asked you, what's the best diagnosis? What are the findings? Splenomegaly. So sickle cell disease, SS disease is not going to be there. The spleens are small and autoinfarcted. Thalassemia can give you a big spleen. So can lymphoma. So can polycythemia vera. In fact, the largest spleens are typically with polycythemia vera or CLL. Then you look at the bone and you see the sclerotic changes, and that's a very good look for myelofibrosis. And putting the two things together, when you have all the bones involved like this, it's not going to be lymphoma. This is not the appearance of thalassemia. This is a great case of polycythemia vera with myelofibrosis. Just a classic example. This patient has a bone marrow transplant and has fever. When I see a BMT patient, you're always thinking about fungal infection. And what do you see here? Cavitary lesions bilaterally. You see some infiltrates. I'm always thinking about aspergillosis, invasive pulmonary aspergillosis. CMV does not give you this pattern. TB is not this population. This doesn't look like septic emboli, which are more wedge-shaped and peripheral. This is a classic invasive pulmonary aspergillosis, a fungal infection. The correct answer indeed is going to be B. In this case, what's the best diagnosis? This is a pretty simple case, but I liked it. There's a large aneurysm of the right renal artery. Look at that aneurysm. It's 1.5 times the aorta. Not much else. Kidneys look okay with a cyst in the right kidney, but a beautiful renal artery aneurysm. When aneurysms get above 1.5 or 2 cm, they typically will be treated. This patient had endovascular stent repair, and the best diagnosis is, now we've spoken before that with endovascular repair, perfusion changes in the kidneys and even small infarcts are not uncommon. But in this case, there's a global infarct of the right kidney. There's basically at best minimal capsular flow. You see the atherosclerotic changes, you see the endovascular stent. So the right renal artery must have been occluded. There also is an infarct, though it's more segmental in the left kidney. So this is a classic example of renal infarcts. In the left kidney, if I didn't give you a history, you could think about pyelonephritis, but when you have an endovascular stent placed, you see wedge-shaped, you're thinking infarction, and the right kidney is very classic for global infarction. This patient had endovascular repair, right-sided access, and what do you see? This outpouching off the femoral artery. That's just a classic example of femoral artery pseudoaneurysm. CT is very good for looking at vascular complications, whether it's bleeding, whether it's fistulae, whether it's an aneurysm or pseudoaneurysm. This is not an AV fistula, though That can be one of the complications. Femoral artery occlusion is rare but could occur. This is a beautiful femoral artery pseudoaneurysm. In this case, I just love the images so much I had to ask you, what's the rendering technique? You can see I've changed the images. On the first image, the one on top, I'm showing you the blood flow, and in the bottom, blood is negative, and I'm showing you the patient's endovascular stent. This is a beautiful use of cinematic rendering. You can do okay with volume rendering, perhaps, but not with the shadowing, so it won't look as good. MIP can show you the stent, but you would not really visualize the soft tissues. And classic and shaded surface ain't going to do nothing. We don't even use that at all. Beautiful example of cinematic rendering. So with that, I've given you 10 terrific cases. I hope you learned something. I hope you like the cases. You can see I put a bunch of cinematic renderings in there trying to get your interest. And I hope you enjoy the rest of the month. Have a great month. Catch you later. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctassist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the July 2019 CTSS quiz. Now, for many people, the new year begins January 1st, but when you're in academics, it begins July 1st. We lost all of our fellows and got a whole bunch of new fellows. Everything starts again. So we welcome the new fellows, and we fondly said goodbye last week to our old fellows. Okay, with that, let's get started. 10 terrific cases. This patient had hepatitis C and right upper quadrant pain. When you look at the liver, you see the cirrhotic liver. Then you see multiple masses and multiple vascular pools, which actually represent a combination of AV shunting, tumor neovascularity, and active bleed. Well, cirrhotic liver, without even looking hard, you go to hepatoma, which is in fact the right answer. This is not the appearance of FNH. This is not a hemangioma. Hemangiomas have peripheral puddling. AV malformations are usually small, or if they're large, you see the AV shunt, but not multiple vascular lesions like this within a very large mass. A very interesting case. This patient had back pain. What's the diagnosis? Two examples of cinematic rendering, beautifully showing the one on the right, the black blood appearance on CT. You can see the aortic valve. You can see the dissection beginning above the valve, extending up into the arch. A beautiful example of a type A dissection. We're looking at how we can use this black blood appearance for looking inside vessels and what other information potentially we can gain. The most likely diagnosis in this case is, when you look at the what is actually basically almost a venous phase image, there's a 2-centimeter mass in the body of the pancreas, which you can see on the cinematic rendering, which is more arterial phase. The mass is particularly bright on the cinematic, well-defined, and a classic cinematic appearance of a neuroendocrine tumor. Neuroendocrine tumors are typically hypervascular, but not always. They can be somewhat cystic, can have some rim enhancement, but typically the smaller ones, solid, hypervascular, and very well defined, as this case was. This patient had a neck mass. What's the best diagnosis? Two cinematic renderings. Beautiful example, image on your left. Look at the vessels being pushed by the large thyroid gland. That's the thyroid. And you can see when I cut through it beautifully the cystic components, particularly on the left side of the gland. This is a classic goiter. It's not a carcinoma of the like a squamous cell. It's not a thymoma. It's not lymphoma. This is a goiter, and that cystic appearance inside the goiter very nicely seen, and a good feel for how cinematic rendering could really be used for preoperative planning as well as for defining extent of disease. This patient has hematuria. What's the best diagnosis? Well, you can see the patient has a hypodense lesion, wedge shape, sharply marginated right kidney. And if you look at the right renal artery, the branch that goes to the posterior part of the kidney, look at the axial image, you can see it's occluded. This is a classic renal infarct due to an embolism to a renal artery branch. Now, sometimes only looking at the axial, you could say, well, infarct versus pyelonephritis. You're not going to confuse this with tumor. And sometimes I agree infarcts and pyelo can look the same or similar in part. Pyelo is more likely to have stranding around the kidney. And a key finding for infarcts is seeing the thrombosed vessel, which we can see nicely in this example. This patient had GI bleed, and when you look at the images, there's a vascular lesion or a high-density lesion in the patient's pelvis adjacent to the ilium. And I've never seen lymphoma be this dense, and I've never seen adenoma be this high density, or even melanoma. Now, I guess we don't know what the lesion looked like without contrast, how vascular it is, but a vascular lesion arising near the small bowel, yes, you could think of a carcinoid tumor, but there's no desmoplastic reaction. What you could think about is a GIST tumor. GIST tumors are commonly exophytic, particularly in the stomach, but also small bowel. They can be very vascular, and this was an amazing GIST tumor that was hypervascular. This patient had a left nephrectomy, and we're doing a routine follow-up study. And when you look, the patient has a 1 centimeter nodule adjacent to or involving the left psoas muscle. And someone suggested that this could be an accessory spleen, which could fall backwards in a patient with a left nephrectomy, but it's not enhancing like the spleen. It's a solid lesion against and involving the psoas, and it's a recurrent renal cell carcinoma. About 10 minutes ago, I read another case that looked very similar. So recurrences in or near the renal bed and renal cell carcinoma, particularly clear cell, need not be very large. They could be 1 centimeter, and it's the vascularity of the lesion that helps you find the lesion. This patient had a cystic lesion by the tail of the pancreas, and I have to admit, what could it be? It could be middle-aged female, it could be the MCN, mucinous cystic neoplasm, but they're usually in the body. It could be an IPMN, that's a possibility. Could be a cystic neuroendocrine tumor, but those usually have an enhancing rim. That cystic is not going to be lymphoma. This ended up being an oligocystic serous cyst adenoma. So again, serous cyst adenomas have a range of appearances, and at times they will fool you because they're just simply large cysts. Look like IPMNs, more common in the head of the pancreas, but can occur anywhere. Now in this case, what is the mass? There's a mass in the head of the pancreas. It pushes and maybe scallops the portal vein and SMV, but it's not invading. The hepatic artery is stretched over the mass. The mass appears to be cystic and solid, with the cystic components best defined on the coronal volume rendered images. Well, this doesn't have the appearance of a neuroendocrine tumor, too cystic for most lymphomas, not a great location for MCN, but the scalloping, the appearance is really good for serous cyst adenoma. And this is another example of serous cyst adenoma to make the point that serous cyst adenomas are not always typical in location or appearance. Now in this case, this is fairly easy. I just like this case because I wanted to remind you about giving oral contrast, be it positive or water. There's a mass, low density in the stomach. You can see the coronal view, how it hangs down. That's not an adenoma. It's not a carcinoid tumor, which would be vascular. It's not a pancreatic rest, which is smaller and vascular. This is a classic GIST tumor. And yes, it's not very vascular. That's good for GIST tumors. Most GIST tumors in the stomach, 70% are exophytic, but they can be intraluminal, and this is a very nice intraluminal example. Well, those are 10 cases, and I hope you liked those cases. I hope you got them all right, but even if you didn't get them all right, I hope you learned something. And even if you got them all right, I hope you learned something. And with that, see you later, alligator. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to our August 2019 CTisus quiz. I hope you're having a great summer. I'm sure where you are, particularly if you're on the East Coast, it's really hot. Baltimore, every day is the same. High 90s, thunderstorms, windstorms, and a whole lot of trees knocked down. Hopefully it won't be too bad this weekend, though everyone tells me it's going to be record highs. But nevertheless, if it's record highs, there's only one thing you can do, and that's do your CTisus quiz. So we have 10 terrific cases for you. And without further ado, let me get started. In this case, I asked, what's the likely diagnosis to explain the right renal artery? If you look at the right renal artery on the coronal view, but especially on the MIP imaging, you can see the beating of the renal artery. And compare that to the left renal artery, which looks perfectly smooth. This is not an aneurysm, though if you only had one little tiny bump, then you would say aneurysm. Obviously, it's not stenosis. Vasculitis can cause irregularity in the vessels, but it's usually areas of narrowing and thinning and irregularity. This is a classic for FMD or fibromuscular hyperplasia. Very, very nice example. Some people call it hyperplasia. It's really fibromuscular dysplasia. Just a really, really classic example. This is a simple case, and today I was at an adrenal conference, is why I showed this case. It wasn't one of the cases from conference, but we always see these people get very excited about these lesions, and they kind of want to work the patient up. If you look at the lesion, it's low density. In fact, you put a cursor, it's minus 30. You look at it compared to the retroperitoneal fat, which is typically minus 80. This is a fatty lesion. It's well defined, incidental. This is an adrenal myelolipoma. It's not an adenoma. Adenomas typically go as low as minus 10. This is minus 30. Carcinomas are solid and irregular and enhanced, and this is not adrenal hyperplasia. So a classic adrenal myelolipoma. This patient presented with chest pain, and what's the best diagnosis? When you look at the axial images, you look at the root of the aorta and you see a dissection. This is a gated acquisition, which is critical. I see mistakes all the time where people don't do gated acquisitions and they assume what they're seeing is motion, or at times they have motion and they'll call it a dissection. We are doing cinematic rendering with this black blood approach, and look how nicely you see the flap within the lumen. This is just a beautiful example of a type A dissection. Just a really good case. Obviously, it's not a motion artifact. It's not an intramural hematoma. And type B dissections begin just past the left subclavian artery. This patient had FUO, and what's the best diagnosis? So you see in this case a large spleen, and there's 4 choices here, and mono, lymphoma, and sarcoid all can give you a large spleen. TB can occasionally, but it's rarer. But then you look and you say, oh my goodness, look at those nodes in the subcrural space. Look at the peripancreatic and paraortic nodes. Now, mono can give you nodes, but this would be a lot of nodes. And sarcoid can give you nodes, but it's rare to ever see subcrural nodes, and these are kind of bulky. And I will admit at times sarcoid and lymphoma can look very similar, but when you see large bulky nodes, subcrural nodes, peripancreatic nodes, and a big spleen, you're dealing with lymphoma, and lymphoma indeed is the correct answer in this case. This is a wonderful case. When you look at the images, you see this quote-unquote foreign body, and then I ask you, what is the device? It isn't there accidentally. And what's it used to repair? Well, when you look at it both on the axial as well as the MIP imaging, and I have the most incredible cinematic renderings here, but we're submitting it to radiology, so I don't want to use it, or radiology won't accept it. You can see that this device is sitting between the right and left atrium. So it's not going to be a VSD. You don't treat atrial septal aneurysms with occluder devices, and this is an Amplatz occluder device, and you don't get pseudoaneurysms there. The classic thing you have is an ASD. We don't see the ASD because it's been taken care of by the Amplatz occlusion device. Just a very nice set of images. In this case, I asked you for the best diagnosis. Well, you say, well, could this be an ASD? There's a bulge between the left atrium and the right atrium. Surely this is not a VSD. It's not a pseudoaneurysm. Could this be an ASD? Well, you can see how sharply defined it is, particularly well shown on the cinematic rendering. That's the classic appearance for atrial septal aneurysm. Just a beautiful, beautiful example of that. Very nicely shown, and typically nothing is done about that. This is a great case, and it's very subtle. And what's the best diagnosis? So what are we looking at? If you look at about the S2 level on the axial, there's a soft tissue mass present, which is better seen on the sagittal view, which is literally in the cord, but the cord doesn't extend it that low, obviously. So what could this be? It's not a meningocele. That's not the appearance of meningocele, and those are cystic. Lymphoma, that'd be exceedingly rare to have lymphoma there. Neurogenic tumor. Typically, if it was a neurogenic tumor, you'd see bone erosion. This is soft tissue mass. It appears to be enhancing. It's kind of a classic location for ependymoma. Just a wonderful case, and I have not seen too many of these cases. This patient had a recent gunshot wound, was discharged, now has thigh pain. What's going on? And they've palpated a mass, and you could see there's a outpouching off the patient's superficial femoral artery. You can see it nicely with MIP and with volume rendering. It's not a hematoma because it's really communicating and enhancing with the vessel. It's not a sarcoma, right? This is a big vascular mass. It's not active bleed because if it was active bleed, you would see changes in the boundary. It's really a well-defined process. It's connecting and communicating with the SFA. And in a patient with recent trauma, be it stab wound or gunshot wound, this is the classic appearance of a pseudoaneurysm off the superficial femoral artery. Okay, just a beautiful image, both on the MIP and on the 3D reconstructions. This patient had right lower quadrant pain, and I'm asking you what's the least likely diagnosis. Well, what do I see? I see a large mass. It's solid. Maybe it's enhancing a bit. It's displacing bowel, but not obstructing bowel. I could easily go with a small bowel GIST tumor. A large duodenal GIST tumor would work well. I could go with lymphoma, but one solid mass lymphoma and seeing nothing else, I'd have a problem with that. But you can get big mesenteric masses with lymphoma, but I'm just not that excited. Is this a hematoma? Well, it's not high density. It's not low density. It's large, right in the mesentery, has mass effect. I just think this is not, I would not consider hematoma. To me, this is a solid tumor. The other possibility is a desmoid tumor, fibromatosis. I would have gone with a GIST tumor here or some sort of sarcoma, but I would have gone with something coming from small bowel. This was operated on. This was a desmoid tumor. So desmoid tumors usually are seen in patients with Gardner syndrome. That wasn't the case here. Desmoid tumors can simulate mesenteric masses, carcinoid tumors, lymphoma, GIST tumors. So it's a great mimicker, but we don't see them all that often. In this case, I'm asking you for the best diagnosis in a 50-year-old with left adrenal mass. So the first thing that's critical to recognize on this case is you don't see the right kidney. And this is a MIP imaging, one of them. The one on the left is volume rendering. So if the kidney was there, you would see it. Now, if you look at this mass, and forgetting everything, if you only had the adrenal circled in, it could be a pheo. It's a large mass, some vascularity, could be a primary carcinoma. Lymphoma, usually a bilateral, but it could be, though usually not very vascular, but I couldn't exclude it. And in theory, it could be metastatic renal cell carcinoma, right? Because it's a solid mass, and any mass can be metastasis. Well, with the patient's right kidney gone, and this lesion being vascular, that pushes you from pheo and adrenal carcinoma over to metastatic renal cell carcinoma. And this, in fact, was renal cell carcinoma. Just a beautiful example of metastatic renal cell carcinoma to the adrenal. And in this case, it was to the contralateral adrenal. Very nicely seen. So with that, I've given you 10 terrific cases. Take a look. We hope you like them. And just to let you know, if you want to see more cases, you can always look at CT as Us for cases, or you can go to the Apple Store and download our iQuiz, which has well over 1,000 of these incredible cases, literally through June 2019. They're incredible. There's discussions, there's references, and you can't beat the price. And with that, thank you very much for your attention. Catch you next time. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the September 2019 CTSS quiz. It's hard to believe it's September. That means July and August and the summer is over, so welcome to the fall. Okay, I have 10 terrific cases for you to look at, and without any further ado, let's get started. Now, in this case, patient has right upper quadrant pain and is hypotensive. What's the best diagnosis? If you look, you see a large mass involving the right lobe of the liver and what appears to be a cirrhotic liver. The mass has areas of neovascularity, and there is extension beyond the surface of the liver. There appears to be blood, and so what I'm looking at is a hepatic mass that has basically ruptured. Now, lymphoma, I once saw a case of lymphoma that bled, but this is not lymphoma, and this is not hepatic AVM. You can argue, is this hepatic adenoma or is it hepatoma? Both of them can rupture and spontaneously bleed, but with the underlying cirrhosis and the real impressive neovascularity in the liver lesion, this is going to be a hepatoma, and this indeed was hepatoma. Hepatomas can spontaneously bleed, and they can rupture through the liver. And the patient was very lucky that it was eventually embolized. You can see in this case neovascularity, also extending into the portal vein. This patient had a very, very extensive tumor. This is a middle-aged female, and this was an incidental finding. And what's the best diagnosis? Or first, what's the least likely diagnosis? Well, you see a vascular lesion, and it's vascular throughout. Could this be a hepatoma? The answer is possible, though the patient doesn't have a cirrhotic liver. FNH, the density is fine, though FNH is usually more homogeneous, often with a central scar. Hepatic adenoma is a good thought. Vascular lesions which have variable enhancement, that is indeed a possibility. But the truth is all three of them are indeed possible. This is not a hemangioma. Hemangiomas have peripheral enhancement with peripheral to central fill-in. So the one thing this is not is hemangioma. And oh yes, by the way, this ended up being an hepatic adenoma. This patient had abdominal pain, and we diagnosed colitis. And I'm asking you, what's the main cause or the most likely cause of colitis? You can see very impressive thickening of the transverse colon and the patient's splenic flexure. So we think about it. Pseudomembranous colitis typically is not focal, though it can be. I've seen it isolated in the rectum and occasionally in the right colon, but not in this location. This really doesn't look like Crohn's disease. It's almost too thick, and it's almost like thumbprinting. It's not diverticulitis. Based on location, based on the prominent thickening, based on the appearance, this is ischemic colitis. And indeed, this patient had ischemic colitis. This patient had surgery with resection. Just a very, very impressive example. This patient had left chest pain and swelling, and what's the best diagnosis? You can see the left breast is really swollen. There's edema in the subcutaneous tissues. There's nodularity. And the more you look, you see there's masses as well. The patient also has a left pleural effusion. The infiltration is particularly nicely seen in the cinematic rendering. Now, breast abscesses and chest wall abscesses can occur, but to be frank, this looks more mass-like. There are inflammatory components present, but there's a solid mass about 4 centimeters on the left side of the breast. Lymphoma rarely infiltrates the breast, and then you'd also see extensive adenopathy. This was an infiltrating breast cancer. The breast is enlarged, it's fixed, there's infiltration in the subcutaneous tissues, infiltration in the skin, and involvement of the chest wall. Breast cancer was the diagnosis. Just a very, very impressive example. The most likely diagnosis in this case, this is kind of easy in a classic case. There's a mass in the root of the mesentery which has calcification. There's desmoplastic reaction. You can see involvement of the SMV with multiple collaterals present, also involvement of the SMA. There's the desmoplastic reaction. Again, sclerosing mesenteritis can give mesenteric masses, but not this appearance and not the venous involvement. This is really carcinoid tumor. Classic carcinoid tumor from the mass, 70% of calcifications, and then the desmoplastic reaction. Just a very, very pretty example. The best diagnosis in this case, there's a vascular lesion in the liver, which has peripheral enhancement, and there are perfusion changes, and then in the venous phase, the lesion fills in. And that's going to be a hemangioma. Now, what I wanted to show this case for was, you see in the early phase, there's very nice perfusion changes around the liver mass. Remember, I speak about how perfusion changes can be seen in Mets, but perfusion changes can also be seen in other lesions, including hemangiomas. And in this case, I definitely would have considered a carcinoid. I could have considered hepatoma in a cirrhotic liver. I could have considered a neuroendocrine tumor. Those are all possibilities. But the peripheral enhancement with the central filling in, this was hemangioma. Again, you got to think about it, and you might worry, could this be something else by the perfusion change? But I showed this to help you recognize that perfusion changes can also be seen in hemangiomas. Now, in this case, patient had chest pain. What's the most likely diagnosis? Large paratracheal and mediastinal nodes, middle mediastinum, anterior mediastinum, paratracheal region. This is a classic case of B-cell lymphoma. Large, bulky nodes. The nodes have some vascularity. This is not the appearance of thymoma. Theoretically, it could be metastatic disease. Renal cell is one of the common mets to give mediastinal nodes. Sarcoid, perihilar, subcarinal. This is too bulky. This is a great example of lymphoma. In this case, I asked for the least likely diagnosis. What you see here, at first glance, you might say, and it's hard with just a couple images, could this be a gastric mass? If this was a gastric mass, you might think about a GIST tumor. But this is mass of the left lobe of the liver. It's cystic, and there are solid components. The solid components make it not a complex liver cyst, and surely not a simple cyst. But a simple cyst would be the least likely diagnosis. This, in fact, was a cystic cholangiocarcinoma, cystic lesions, atrophy of the left lobe, replacement of the left lobe, and solid masses. It could be a biliary cystadenoma or cystadenocarcinoma. Those are often cystic, septations, and nodularity, so that would not be a bad thought. But the thing this is surely not is a simple cyst. Again, what's the best diagnosis in this case, and what's the least likely diagnosis? So I'm asking you for the least likely diagnosis. The first image on your left, you see diffuse thickening of the esophagus, and it could be bad esophagitis if you're immunosuppressed, though more likely it's esophageal cancer. There's collapsed left lower lung, and then you go a bit higher at the bifurcation. You can see this tumor infiltrating the middle mediastinum with encasement of the left mediastinum bronchus. In fact, this could be a small cell lung cancer growing posteriorly to involve the esophagus. It could be Mets to the mediastinum, though Mets involving the esophagus is rare. And in fact, this was esophageal cancer which spread and involved the left mediastinum bronchus and infiltrated the mediastinum. That's the likely diagnosis, and that's what it was. This is not simply just esophagitis. Bad esophagitis, you can see free air, you can see some nodes, but you don't see the infiltration around the airway, and you don't see the extent of tumor as we see in this example. Just a very nice case. Now, this was an incidental finding, and you see a cystic mass on the left cardiac border, oval, well-defined, abuts the heart. Could it be a bronchogenic cyst? In theory, yes, but bronchogenic cyst, not a great location, usually subcarinal or paratracheal in location. Could this be a cystic lymphoma? Lymphoma can be cystic, but usually after chemotherapy, and this just doesn't have that appearance. It was an incidental finding, and it's not a great location for being the only component of cystic lymphoma. Could it be an abscess? Well, it's water density, no air bubbles, no inflammation, so that would be unlikely. The best diagnosis, and what this was a pericardial cyst. Usually pericardial cysts are anterior at the cardiophrenic angle on the right, but they can occur on the left. They can occur in this location, and this was a pericardial cyst. Well, those are 10 cases. We gave you some abdomen, we gave you some chest, we gave you some of everything. I hope you enjoyed the cases. I hope you're having a great fall season. And with that, as the song goes, we'll see you in October. Actually, the song went see you in September, but nevertheless, I'm seeing you already, and we'll see you next month. Have a great day.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctss.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the October 2019 CTSS quiz. It's amazing how quickly we've gone from summer into fall, and I hope you're having a pleasant fall season. So let's get started. We have 10 terrific cases for you. So without further ado, let's look at the first case. In this patient, middle-aged female, what's the best diagnosis? At first it looks subtle, but you realize there's a mass with increased vascularity in the left lobe of the liver. It's enlarging the left lobe, particularly when you look at the coronal view. Now, it doesn't have the peripheral puddling. Remember, this is arterial phase. It's enhancing, but just about as bright as the IVC, but it has more of an irregular enhancement than you would see with FNH. Hemangioma doesn't have the peripheral enhancement. I guess you would be stuck hepatoma versus hepatic adenoma. Now, there's no evidence of cirrhosis, and you typically or commonly will see cirrhosis as a hint making hepatoma, but we can see hepatomas in patients without cirrhosis. But this pattern of enhancement, the way the lesion looks, middle-aged female, the most likely diagnosis is going to be hepatic adenoma, and this in fact was resected. In this case, what's the best diagnosis? And you can see from the images I'm targeting the right renal artery, and the right renal artery has a classic beating appearance. It's not stenosis, it's not a dissection, and it's not an AVM. It's classic fibromuscular dysplasia, can involve multiple different vessels, though most classically involves the renal artery, can be a cause of hypertension, and this is a beautiful example. It's most common in the mid portion of the renal artery, which indeed is the case in this example. This patient has chest pain. We were doing a rule out coronary artery disease, rule out dissection. And it's a very nice example. So I give you a few choices. But when you look at the axial images, you see the left main coronary and you see this plaque in the LAD, but you notice there's a vessel running between the ascending aorta and the main pulmonary artery. And that's the right coronary. And you can see it again when you look at the cinematic view from above. You see how the right coronary is beautifully shown in 3D, how it tracks between the ascending aorta and the main pulmonary artery. And this is anomalous origin of the right coronary off the left cusp. This is one of the what's called malignant configurations where the patient can experience sudden death. You can see here the coronary is small, and you can imagine the compression of the origin of the vessel when the patient is in systole. So obviously it's not a normal coronary artery, it's not stenosis, and it's not aneurysm. So a really nice example of that. In this patient has hematuria. What's the best diagnosis? So when you look at the images, axial and coronal, what you really see is essentially delayed function of the left kidney. Now, delayed function can be to things that happen to the renal artery or even renal vein, perhaps. It can be due to infection, it can be due to global infarction, and it can be due to tumor. In this case, it's really an infiltrating process. In theory, you could think about a renal cell, but it's really more infiltrating rather than a dominant mass. You can think about METs, renal abscess. I guess you can have a diffuse pyelonephritis, but just the way it extends to the hilum, and again, it's a little bit tricky based on the lack of images I gave you, and in real practice, you would have some delayed phase imaging as well, but this was a nice example of an infiltration of the kidney by transitional cell carcinoma. Just a really nice example. This patient presented with abdominal pain, and I asked you what's the best diagnosis. You see a coronal view, and then you see a coronal MIP view. What you see is the small bowel in this arterial phase imaging is dilated, fluid-filled, But you can see it's not enhancing. That means it's ischemia. You also see the branch vessels off the SMA are really tapered. And you follow the SMA downward, but look how you lose all of the vessels. And yes, the patient does have ischemic bowel developing. It's not a poor contrast injection, obviously. You can see the vessels, and it's not an intussusception. This is the classic example of twisting of a midgut volvulus. Surgical emergency. This patient went to surgery. Fortunately, they could undo the midgut volvulus, and the patient's bowel then became pink, and the patient did well. So the key is early diagnosis. This is also a good example of why in abdominal pain we love to give IV contrast. I'm always concerned if you don't give IV contrast, you can miss things. Very, very important. Now, this patient has HHT disease, and what's the best diagnosis? This is hereditary hemorrhagic telangiectasias. And what you see is arterial to venous. Look at all those vascular lesions in arterial, and it's gone basically on the venous. This is not a hepatoma, and it's not Mets, and it's not abscesses. Patients with HHT disease, they classically get pulmonary AV malformations, but we also see AVMs in multiple other organs. And you want to call these multiple AVMs, you want to call it telangiectasias, regardless. That's what it is. Can be focal, but usually it's diffuse in the liver. Don't confuse it with other pathology. Just a really nice example. This patient has an incidental adrenal mass. Well, you can look on the non-contrast, and you can see also on the arterial. The lesion does enhance, but really the key thing is the fat in the lesion. Now, yes, you can get fat in adrenal carcinomas, but that's punctate fat with an enlarged mass that typically has dystrophic calcifications as well. This is a well-defined, incidentally detected adrenal lesion. It contains fat. This is classic from myelolipoma. Yes, it is enhancing, and yes, the whole lesion is not fat, but for myelolipomas, you just need a little bit of fat, and there's a range of appearances. This patient has hyperglycemia. What's the best diagnosis? Well, without looking at the images, if I say hyperglycemia, I know I'm looking for an insulinoma. Now, insulinomas average about 1 centimeter in size. They can be multiple, but they can be difficult to detect. Now, with good scanners, CT angiography, MIP, 3D imaging, you can see in this case there's a lesion, though it's subtle, 1 centimeter in the tail of the pancreas, better seen on the blown up view that I give you on the right here. That's just classic. Now, if I told you this was a non-functioning neuroendocrine tumor, could be. And neuroendocrine tumor is D. That could be the correct answer, but I said the best answer. Hypoglycemia, the best answer is this is a neuroendocrine tumor, which is specifically an insulinoma. Just a very nice example. I do find it at times it's difficult to make the diagnosis of insulinoma. It's very easy to miss small lesions, particularly under a CM. You need to be very careful, particularly looking at the images in multiple planes. Now, in this case, I ask you, what's the best diagnosis? What you see are multiple vascular lesions in the head and body and tail of the pancreas. So what could it be? You could have multiple neuroendocrine tumors, I guess, and you can get that particularly in von Hippel-Lindau, not so much MEN1. But you see the left kidney, which looks okay, but you don't see the right kidney, and there are some clips present. It's a little subtle, and if I gave you more image, you would see the absent right kidney, which indeed the patient has an absent right kidney. And the patient originally had clear cell, and this is metastatic renal cell carcinoma. It's rare to see Mets at presentation. Usually it's a patient who's been treated well, and it's 10 to 15 years after diagnosis. We are seeing many more metastases to the pancreas as the only site of recurrence. Just a really nice example. This patient in right lower quadrant pain, what's the best diagnosis? When you look at the images, you see a tubular structure in the right lower quadrant, which you know is the appendix. And at first glance, you say appendicitis because it's dilated and maybe there's some stranding. But in the proximal appendix, there's soft tissue. So this is not diverticulitis. I guess you can still consider appendicitis. It's not a Meckel's, but this is a mucocele of the appendix. Soft tissue mass, often right at the appendix cecal junction. It obstructs the appendix. Often you get very large appendix, see a soft tissue mass, and the patient needs to have resection of the cecum and the appendix. So that's a mucocele of the appendix. Something very easy to miss. At times it's easiest seen on the coronal views. So with that, I've given you 10 absolutely terrific cases. I hope you enjoyed the cases. I hope you learned something. And I hope you have a great October 2019. Catch you later. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to November 2019 CTSS Quiz. November means RSNA is around the corner, and it means yesterday you celebrated Halloween, which means I'm going to show you 10 cases, all treats, and no tricks. So let's get started. On this first case, I asked you what the best diagnosis is. You see two cinematic renderings. There's an NG tube in place, and perhaps the image on the right is easier to appreciate. You see the descending thoracic aorta, and then you see a vessel going from left to right. You also see the azygos on the right side, but the vessel crossing from left to right is classic for an aberrant right subclavian artery. It can indent the esophagus. Usually it's asymptomatic unless you have an aneurysm of the right subclavian artery. So just a beautiful example, also showing you very nicely how cinematic rendering works for looking at vessels. In this case, I asked you for the best diagnosis. There's an obvious pancreatic mass, solid and cystic with calcification. Now, if the patient was young and you wanted to say this is a SPEN tumor, I would say you're right. But middle age, occasionally gets SPENs, but usually not. Adenocarcinomas don't have that dense calcification. You could sometimes see calcification if adenocarcinoma arose in a patient with chronic pancreatitis. Serous cystadenomas have central calcification, sometimes stellate calcifications, but they're not cystic and solid. This is a malignancy. If this was a cystic tumor, it would be a malignant cystic tumor, not a benign serous cystadenoma. So when I see a solid mass in solid and cystic with coarse calcification or funny calcifications, I'm saying a neuroendocrine tumor. Neuroendocrine tumors will commonly calcify, and this is an excellent example of such. Now in this case, it's very simple. What is that muscle group? You see a whole bunch of the same muscles. They're all attaching to the ribs. It's obviously the serratus anterior. I think all of us at times forget to learn the muscle. We know the pectoralis major muscle and pectoralis minor, maybe the latissimus dorsi. We need to know all the muscles. Just a very nice example. And in trauma, you can see injury to the serratus anterior. There was just a football player, I forgot from what team recently, who had a insertion of the serratus disrupted, and now they can't throw. So it's important, particularly if you're the radiologist for a football team. In this case, what's the best diagnosis of abdominal pain? This is a mass vascular with neovascularity. To me, it's a malignancy, so I don't look very much past hepatoma. If you said hepatic adenoma, I couldn't argue because hepatic adenomas become hepatomas often. So it would be a hepatic adenoma with looking like hepatoma. It's not hemangioma, you don't have the puddling, it's not FNH, it's not homogeneous. You do get feeding vessels, but they're central. This neovascularity, this is hepatocellular carcinoma or hepatoma, even though the liver is not cirrhotic. This patient had chest pain. We were doing a coronary CTA for coronary artery disease. And what do you see by the right coronary? There is a calcified lesion, which is occluded in part, classic for a right coronary artery aneurysm. The coronary artery most commonly involved with coronary artery aneurysms is indeed the right coronary artery. Not the circumflex, not the LAD. This can lead to infarcts, but I don't see an infarct, and this surely is not a dissection. A beautiful example of a right coronary artery aneurysm. Now this is a great case, a typical abdominal pain. What do you do with this? I know the first thing you're thinking about, could this be a pancreatic mass? If this was pancreas, it's a neuroendocrine tumor, but it's not the pancreas because the images of the pancreas are normal and this is too low already. It could be a mesenteric mass like a carcinoid tumor, but then you see desmoplastic reaction, maybe you see a mass in the small bowel, but you always see desmoplastic reaction, and you're not seeing it here. I have heard of cases of TB with calcification, but that's like peritoneal seeding, and the patient's usually from Africa. I was once quizzed on a case of a patient from Ethiopia. Sclerosing Mesenteritis is one of those tricky diagnoses. It's often confused with other things. It's often hard to prove short of surgery, and it's hard to prove on biopsy. But this is a good example. The PET was negative. The patient was asymptomatic related to this. Sclerosing Mesenteritis is the right diagnosis. 50-ish-year-old female with distension, the best diagnosis. You can get extensive ascites from liver disease, cirrhosis, but this is not liver disease, and this is more than ascites. Look at the appearance around the transverse colon. That's carcinomatosis. It's not the ascites from renal failure. And yes, gastric cancer can give you carcinomatosis, but the stomach, at least what we see, looks good. So this is carcinomatosis from ovarian cancer, often extensive ascites, implants on the liver and spleen, diffuse infiltration in the omentum, implants, you name it. This was ovarian cancer. This patient was febrile, and I asked for the best diagnosis. Again, you could consider this as a tumor, a cystic renal cell carcinoma, relatively hypovascular, maybe somewhat necrotic. But in a febrile patient, you need to be thinking about an abscess. Yes, people with carcinomas can be febrile. Lymphoma, they can be febrile. Transitional, probably not. And yes, lymphoma can be necrotic, but the appearance of this, the changes in the perirenal space, you got to be thinking an abscess, and this was an E. coli abscess. Again, we often forget about abscesses in the liver and the kidneys, and that often delays the proper management and diagnosis of the patient. So think about it. Here you simply get a urine culture and you have the right answer. The most likely diagnosis in this case, large mass. It looks cystic. It probably involves the kidney, involves the right psoas muscle. It's not lymphoma. That's usually solid. When lymphoma is cystic, then you're typically going to appreciate treatment. This is not just a mesenteric cyst. They may have thin septations, not solid components, and they don't involve the right psoas muscle. Adenocarcinoma, nah, that's not how it looks. This is classic for liposarcoma. Most common retroperitoneal sarcoma, yes, it's a liposarcoma, but where's the fat? Liposarcomas often have minimal fat, or in this case, no fat. Just a beautiful example. Now, if you were dictating it, you would say it's a sarcoma. Could be a malignant fibrocystiocytoma. It's an aggressive malignancy, but liposarcoma is a good choice, and that's what it was. This patient with right lower quadrant pain, I want to share a really nice case of this entity. Look at the distal ileum. Look how it's enhancing. Look at the prominent vessels, the so-called comb sign. That's the classic appearance, and I gave you two really nice views of active Crohn's disease. It's not the appearance of ischemic enteritis. This patient is not a small bowel obstruction patient, and this is surely not appendicitis. Crohn's disease is classic for comb sign. You can see the comb sign at times with other things, GVH or other inflammatory processes. The enhancement of the bowel, again, great for Crohn's, though not specific. But together, I think in Crohn's disease, and Crohn's is the answer. So with that, I've shown you 10 cases. I hope you have a great month. I hope to see you at RSNA. And I hope to see you around CT as Us, Facebook, Instagram, Pinterest, Twitter, on the App Store, 16 apps and counting. And we'll see you next month. Have a great day. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctasus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hi, this is Elliot Fishman, and welcome to the December 2019 CT is Us quiz. It's December. That means RSNA is going on. It also means this is the last quiz of the year. 12 amazing quizzes, and you can see all of them and all the information online at ctsus.com or on our app. And the new version of the app will be out in January 2020. That sounds very weird, but it will be there then. Okay, I have 10 great cases for you, so let's get started. On this first case, beautiful cinematic renderings. I'm looking at the anterior chest wall from behind. I have arrows pointing to a vessel. What is that? I gave you 4 choices, but there's only one choice. That is the correct answer. Those are the internal mammary arteries. just beautifully shown on this CT scan. Again, cinematic is really good for looking at the detail of muscle, and you can see this on our new app of the chest using cinematic rendering, which will be in stores soon. The most likely diagnosis in this case, this is kind of just a nice example, but I showed you this. This is a classic type A dissection, nearly down to the coronary arteries. Beautiful differential enhancement of the true and the false lumen. The ascending aorta is dilated, and this only went into the proximal arch, but a beautiful example of a type A dissection, and this patient had repair and did fine. But you can see the danger and the importance of CT in looking at type A dissections, trying to find precisely where the dissection goes and how close it comes to the coronary arteries. The most likely diagnosis in this case, well, when you look, you see multiple enhancing lesions in the pancreas. So you can say, well, this could be multiple neuroendocrine tumors in a patient with an MAN1 syndrome, let's say. It's not going to be hemangiomas, obviously, and it's not going to be mucinous tumors. But what you notice here is the liver rotates posteriorly, the bowel falls posteriorly. This patient has had a right nephrectomy, which means the patient had a renal cell carcinoma, and these lesions are all hypervascular lesions or metastasis to the pancreas from clear cell renal cell carcinoma. We've spoken about this before. What's most interesting is that the pancreatic mets happened nearly a decade or more after the original presentation of the patient's tumor. A very unusual recurrence, but we see that not uncommonly. The most common metastasis to the pancreas is from renal cell carcinoma. A couple good facts. In this case, I asked you what's the best diagnosis. You're looking at a coronal view and a cinematic view, and what you notice is the pancreas is enlarged. You can see particularly on the cinematic the textural changes by the distal body and tail, and there's a halo appearance around it. This is classic for autoimmune pancreatitis. It's not pancreatic cancer, and it's not lymphoma. I guess you could say it's acute pancreatitis, but the halo takes it from acute pancreatitis to autoimmune pancreatitis. We need to be precise in CT these days. Just a beautiful example. The best diagnosis in this case is, well, what do we see? There's a large mass in the right breast. There are subcutaneous nodules. There's axillary nodes. There's right hilar nodes. There's also a mass in the left breast. I guess theoretically you could say metastatic melanoma, and in theory you could say lymphoma, but this is a female, and with the multiple nodules, with the masses by the internal mammary, the best answer is going to be metastatic breast cancer. But I guess I got to give you partial credit if you put down melanoma. I have seen melanoma look like this, and I have seen lymphoma as well, though less commonly. In this ER patient with abdominal pain, what's the best diagnosis? And what you can see here is the stomach is well distended. There's a metastasis or a mass in the liver, and diffuse infiltration of the body and antrum of the stomach by carcinoma. I'm showing you this case to make the point that when you're doing ER patients, you have to distend the stomach. If the stomach wasn't distended, you might miss this lesion. So whether you're using positive contrast or water for a neutral contrast agent, ER patients need a distended gastric fundus, body, and antrum. 1,000 cc's of water over 20 minutes, or at a minimum 500 cc's 5 minutes before, is going to solve the problem. Just do it. In this febrile patient, the best diagnosis is, when you're looking at the axial images, you can see the gluteus medius muscle looks enlarged, and there's high density within the muscle. There are ovarian cysts, and there's fluid in the uterine cavity. And then when you look at the cinematic, look at the differential enhancement and texture changes in the gluteus medius muscle. The muscle's enlarged, increased attenuation zones present. That's not the appearance of an abscess, plus bilateral abscesses, and following the muscle planes would be unusual, to say the least. It's not lymphoma because it's too symmetric. It's not necrotizing fasciitis because we don't see air, and that's typically, you're going to see some air or tissue necrosis. It's myonecrosis, myositis, myonecrosis in that spectrum. Just a beautiful, beautiful example. I asked you the key finding in this case in what organ. Well, the key finding is look at the adrenal glands. Look how bright they are. There's periportal edema. There's a little bit of ascites. This patient is in shock. The patient's hypotensive. Classic appearance. Very bright adrenal glands without mass effect in any of the limbs. That's classic for hypotension. A very important diagnosis. In many cases, we can make the diagnosis before the clinicians are aware of the diagnosis. The liver lesions in this case are most likely, well, one thing you can see, look at the Ho image. There's a large mass in the tail of the pancreas that's enhancing. It's solid and it's cystic. Now you say there's lesions in the liver, so I know they're going to be Mets. And they're going to be Mets from that tail of pancreas tumor, which make it a neuroendocrine tumor. Now, if I didn't have the pancreas, I still would worry about metastasis. It doesn't look like FNH because there's sort of rim enhancement and central low density. It's not hemangiomas because you don't have puddling. Theoretically, it could be multifocal hepatoma, but the patient's liver is not cirrhotic, and this was a metastatic neuroendocrine tumor of the pancreas. The patient has an acute abdomen. What's the best diagnosis? The key finding is air within the hepatic veins. Beautiful example, axial and coronal. When you see air in the hepatic veins, you better be thinking about ischemia and infarction. Yes, I can see it post-procedure like a biopsy or ERCP occasionally. You also notice here the patient's right colon has pneumatosis. That puts it all together. Pneumatosis, air in the hepatic veins, classic for ischemic bowel. This is not hepatic infarction, and it's not bowel obstruction, it's not a liver abscess. This is ischemic bowel. Just a beautiful example. So with that, I give you 10 cases, and it finishes up the year. Now, I wish everyone a happy and healthy new year, but I also recognize some of you may not be watching this for another 3 or 4 months. So whatever month you're in, may you have a happy and healthy that month. Have a great day, and we'll see you January 2020. Bye.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctss.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.